Great, thank you. So again, yeah, welcome and good afternoon. My name is Robin Ray. I am a cardiologist at St George's Hospital in London, and I'm going to take you through this second live doubt clearing session. I appreciate it's been a very long day. We have about 100 slides to get through in the next 3 hours or so, and I know it's been a long day for all of you that were there for the first part. So I'm going to try and get through this a little earlier if possible. We're going to go and start easy, and then we're going to gradually get harder and harder. As I say, I am a cardiologist and I don't practice general medicine. So I actually took the same test that some of you have taken, and I'm pleased to say that I passed. And I think it's in part because you can improve the odds of passing by doing a number of things, but also I think it's a reflection that the exam is actually relatively clinically based, and a lot of these cases and scenarios that I'm going to go through, I've actually experienced in real life over the last few years as a consultant. We went through a few study tips before, and the key thing to try and pass the MRCP is study, 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 but it's also the technique that you use. And the more MCQs that you do, it's been proven that the more likely you are to pass the exam. And by numbers, I'm talking thousands. So you need to probably do at least 4,000 MCQs to stand a good chance of passing at least first time. And the more times you take it, actually, your chance of passing is actually a little bit less. And as was mentioned in the first session, try and focus perhaps on one book, a small book, not a large book, and then balance that with your clinical studies, but also lots and lots of MCQs. And that's the basis behind this revision course, in the sense that we're going to go through questions, but what I'll do is I'll try and teach the way that I approach questions. There's a lot to go through, so I'll probably try and give you maybe a couple of breaks, 1 or 2 breaks of about 5 minutes, so that you can relax, and then we can hit the MCQs again. So let's start. Okay, so the first question. A 45-year-old woman underwent silicone breast implant which started to leak after a week. Tissue biopsy was taken from it and found to be rich in foam cells. What is the cell lineage? What is the cell lineage of foam cells? And you've got 5 answers. As you know, it's the you have to pick one out of these, and it's sometimes the best answer, and there may be more than one answer that's relevant, so you have to pick the best one. So I don't know if people can reply at all. I've got the messaging up here. And I think the way that we're going to do this is probably I will try and speak as much as I can. But for those questions which are a little bit difficult, I'm going to try and ask you guys to answer. And when I do, I really expect you to reply. So just reply in the messaging in terms of A, B, C, or D. So another type of technique to answer to look at with these questions is when it asks you about when it asks you a question like this. Often I read the questions backwards. So if you read this question backwards, the last line is, what is the cell lineage of foam cells? By reading that, it basically means you can save time and you don't need to read the first 2 lines, okay? So the answer is foam cells. Eosinophils is incorrect. As you know, that's more parasitic infections, allergy. Fibroblasts, well, these are the most common type of cell found in connective tissue. They lead to kind of collagen production, leading to healing wounds, scar formation. T lymphocytes was another answer. That's more kind of adaptive immune system. B cells, humoral immunity. But the answer is foam cells. And as a cardiologist, this is something that I obviously know about in terms of the pathophysiology behind plaque formation within arteries. And you get localized fatty deposits in blood vessels. Macrophages ingest LDL, so fat. They become laden with the fat and the lipids, and it gives them this kind of foamy appearance that you can see in this right picture. Okay, so moving on, next question. A 65-year-old diagnosed with carcinoma at the junction of the lower third of the esophagus and stomach, proven liver metastases, and is unsuitable for surgical resection. The tumor has been shown to be human epidermal growth factor receptor 2, so HER2 positive. What's the most appropriate drug for the treatment of his condition? So this question potentially is a little bit difficult. And I think when you look at this question, the key thing here is that the cancer is HER2 positive. So unless you know what HER2 positive means, it's going to be difficult to answer this question. I think if you don't know the answer, because you know that this is not negatively marked, you need to just tick one of them and then move on to the next question to save yourself time. You're not going to gain time by looking through this. So HER2 positive. So as a cardiologist, I managed to get this right. So trastuzumab is the answer, which is also known as Herceptin. So HER2 positive, Herceptin. And the HER2 receptor antagonist, so Herceptin, can be used in combination with other chemotherapy in the treatment of HER2 positive tumors. So this is a gastric tumor, but we often use it for breast cancer as well. And you're probably aware that if you give Herceptin to patients, it can lead to LV impairment and heart failure. And so as a cardiologist, I'm involved because we have to do numerous echoes in terms of surveillance to make sure that the LV function doesn't deteriorate. So this is a question that either you know or you don't. If you don't know it, just answer and move on. Otherwise, HER2, think about Herceptin and trastuzumab.